Hello, my name is Kathleen Listen. I'm a lymphedema therapist. I'm a board certified massage therapist in private practice in San Diego, California. And I want to use this video to give you the clinical pearls that I learned at a recent Medi lymphedema therapy class that I attended at Dana Point in California. So we'll start with some statistics, and then I'm going to go into the several pages of tidbits, clinical pearls that I learned from this education. And I'll start by inviting you to go to the Medi University website. That is where you will find out if one of these classes is going to be held in your area in the future. That's where you can sign up. That's where you can find their online webinars, their online courses. Everything is free. It's a great resource for lymphedema therapists. But let's go into some information, and this is information. It's venous insufficiency and venous leg ulcers, a clinical overview by both Medi and Connie Cares. This is some really good statistics because 10 years ago when I got into lymphedema therapy, I got into it because I was an oncology massage therapist and I was going to use manual lymphatic drainage to help people with lymphedema as a side effect of their cancer treatment because I was an oncology massage therapist. Now we are seeing in America that it's not cancer-related lymphedema, it is venous-related lymphedema that is the number one most likely client to come into and request treatment. There are more cases of lymphedema because of venous disease than there are because of oncology and side effects of cancer treatment. So let's look at the key statistics for venous disease in America, and they should surprise you. 190 million people plus Americans affected by chronic venous disease. So out of all the Americans, over 190 million of us have problems with our veins. I myself have problems with my veins. And of those, 50 million plus Americans are affected by CVI, which is the most severe stage, chronic venous insufficiency. And if someone gets chronic venous insufficiency, they have a 3 times increased risk of all-cause mortality. This is a statistic that should make everyone sit up in their seats, especially if they think that their venous disease is not that serious. If it's just little varicose veins, it's just a little leg swelling, it's just the telangiectasias or the spider veins. If that lymphatic disease progresses to the most severe state of CVI, they have a 3 times increased risk for all-cause mortality. This should make us concerned, especially if you're also helping clients on a longevity medicine protocol. It's important to understand the role of venous disease. Okay, so let's go into some of the clinical pearls that I found. So a lot of these are going to be things that you already know, but it's good to kind of remember them and let them factor into how we help our clients. So when we're talking about venous disease, understand that the superficial venous system is underneath the skin, but the deep venous system is surrounded by muscle. That's why moving the muscles, getting the exercise is so important because the muscles are helping the deep venous system. The most popular cause of CVI, that chronic venous insufficiency, is reflux. So 70% of people who have CVI have it because they have venous reflux. Their veins aren't working that well. The blood is refluxing back into the system. Only 30% of the people with CVI have it as a result of an obstruction. So that would be something as blocking the venous system. Could be a DVT, the result of a DVT, something else. It's mostly a weak valve issue. Their valves are weak. And this is also affecting our lymphedema clients, even if they don't know they have venous disease. We need to be suspicious because this, and Brian Grillo was the educator in this class, and he brought up that this was something that he saw and giving this information to us. Some clients, you put compression on them, lymphedema clients, and that you get quick results. They are coming down, they're reducing very fast. You think you're so successful, you're patting yourself on the back. This stuff really works. That's great. They may have both lymph and vein issues, and the compression is not only helping their lymphatic system, it's also helping their vein system. And if this is the first time they've had compression, you're getting that double benefit of the lymphedema grade of compression, which is the flat knit garment, really also helping their veins, and that's why they're reducing so fast. But if their compression, you put the same clients looks the same on the outside, right? But you put compression on them and it's less effective. You can't figure out why it's taking so long to get that swelling down. They may have a venous obstruction issue. That may be the difference between you're applying the same good quality treatment that we learn in CLT class. Some people are passing with flying colors, other people are really struggling. It may be in the venous system, and the venous system, the weak valves may be why we're getting such a good result, and obstruction may be why it's so tough to reduce some people. All right, so and the truth is that we were shared, and I definitely believe it. The medical system doesn't really recognize vein disease until someone has a wound, until they have that first ulcer. And the wound care compression temporarily helps the phlebolymphedema. But if someone has an ulcer, if someone has a venous ulcer, they are over C3 on the SEEP scale, and you can Google the SEEP scale to see that scale. They are over a C3. They're up in the wound area, venous ulcer area of the SEEP scale, so they definitely have edema before that. And if someone is C3 and above, they have lymphedema, not just a vein issue and some edema. They have lymphedema too. So the wound care compression is temporarily helping them, but anyone that has a venous leg ulcer should be referred to a lymphedema therapist for ongoing care. We need to take hold of all of those clients. And then we talked a lot about compression and how for far too many people, they're getting a pair of socks and they're putting a pair of socks on in compression socks, but they're not putting the correct socks on. They need the graduated compression, but they're also not getting the correct dose of compression. It's not high enough, and they're only wearing the compression that feels comfortable for them, or someone has not really explained to them why they need a higher grade of compression and why we need to figure out what we need to do to get the correct level of compression on them, because too low a dose of compression, so like the 15 to 20 compression instead of the 30 to 40 compression, the 20 to 30 compression, it will just take the edge off of their venous issue. It will not solve the issue. And then my personal opinion is, at the end of it, they have a drawer full of socks. They never really use them because, quote, compression never really works on them, because they never really got the chance to properly try the proper level of compression. It's kind of like feeding somebody a side salad and them saying, getting enough fruits and vegetables doesn't work for me. They need to have the proper dosage in order for you to really see a difference. So dosage makes the difference. Phlebolymphedema is not a diagnosis, and we don't do diagnosis. We don't do kind of insurance. This is more of an insurance comment. But lymphedema, the word lymphedema is for the documentation, not phlebolymphedema. Phlebolymphedema is not a disease. It's not a diagnosis. It's a term that we use, but the proper term to actually use is they have lymphedema. All right, page 2. We talked about the STRIDE documents, and I love the STRIDE document. There's it's available as a free PDF on the internet. The STRIDE document, it's STRIDE, which is the different ways that you come to a conclusion of how someone gets a specific type of compression by using this STRIDE formula. So S is for shape. So that's, do they have more of a conical shape? Do they have a normally shaped limb? Do they have lobes? We're going to give them a different type of compression, like flat knit, custom made compression. If they have lobes, if they have an unusual shape to their limb. T is texture. So the texture, the more firm of the flat knit, and possibly using textured compression is more if they have pitting edema. If they have fibrosis, you're going to give them a different texture than if it's a more watery edema. How quick is their refill? If you take the garment off, how fast are they swelling back up? And they're going to need more compression if they refill faster. And they're going to need nighttime compression, and they're going to need to understand how important it is to keep the compression on. They can't have a day off. They can't have mistakes here and mistakes there, and they forget to wear it and they don't bring it, and there's hours here and hours there, because that's how your leg gets then too large to wear the custom made garment, the size of garment that you were given initially, because you did not keep up with the fact that you have a fast refill as a client. I is for issues. So that's the other side of the coin. What barriers to being able to don, being able to doff, being able to wear this compression does the client have, and what creative solutions can we do to help them overcome those barriers? D is the dosage, and that's often the only thing that you get. The only thing that people kind of know is the numbers, 15 to 20, 20 to 30, 30 to 40. How many millimeters of mercury is the dosage? And then, but understand that the same dosage, so a 20 to 30 circular knit garment is going to give you a different experience than a 20 to 30 flat knit garment. So we can't just say that 20 to 30 is the same in all different types of garments. It's much more creative and complex like that, which is why we have to take all this ongoing education as lymphedema therapists to truly understand the garments. And then the E is the etiology. What is the diagnosis? Why does this person have lymphedema? All right, so we talked about advanced venous disease. I love that this class was mostly about venous disease. And just one of the clinical pearls was, do not use a circular knit on lipodermatosclerosis. So lipodermatosclerosis is advanced lymphatic disease. It is where the limb is differently shaped, differently colored. You'll see that dark rust staining on the leg, and it will look like an inverted champagne bottle. That is not a circular knit type of situation anymore. It requires much more detailed compression in order to help that client, because when you feel that part of the leg, the lower leg, it is hard. It is no longer soft. So yes, so then refill is how fast do you reduce the swelling and how fast do you swell outside of the garment. Dosage is the number, gradient. So for the grade, so then we had the three ways that you would choose, the three factors that you would look at for compression. The dosage is the number, that's the amount of millimeters of mercury. So the 20 to 30, the 30 to 40. And then the gradient is there's difference between proper medical compression, like raw certified compression from Germany, and internet compression. So I don't know if someone on the internet is selling a stocking and says it's, like it's a gradient compression, there's no way for us to know if that's true. There's no way for the client to know if that's true. It's only the garments that are produced in the countries where they have to follow these strict standards that we actually know that it's a fact, because garment stockings on the internet can say whatever they want to say. No one is double checking them. No one is telling them they have to take their product off the market. Okay, and yep, so I said non-lymphedema medical compression doesn't care about gradient compression, so we have to know about that. So that's dosage, gradient, and then containment. So if the garment pinches or buckles on the client, it's not enough containment. it's not enough. So if there's any way that the garment is pinching, it's buckling, it's like cutting in on the client, they have to go into a stiffer fabric. They have to go into a flat knit garment. And then also, if someone has peripheral arterial disease, PAD, they'll have the ABI, the ankle brachial index, where they take the blood pressure on the arm, and then they take the blood pressure at the ankle, and then they do a calculation. And based on what the percentage is, difference in between the arm and the leg, there's the formal calculation for it. And they'll get a number, like a point something something or 1 point something something number. If they are under 0.79 for their ABI, so they have some serious peripheral arterial disease, they cannot have elastic compression anymore, because elastic compression has a high resting pressure. And the problem with arterial disease is they're not getting enough blood in through the arteries. So if someone has an ABI of under 79, they can no longer have elastic compression. They can still have compression. It can't be that elastic compression, because the elastic compression, the stockings that everyone wants to wear, high resting pressure. They have to go into a different type of compression. And then we talked a little bit about how would you tell if someone was not diagnosed with peripheral arterial disease? What are some ways that they're telling you that these interesting things are happening, unusual things are happening with their legs? And that could kind of tip us off as the massage therapist to say, hey, I think you need to tell this to your doctor. You need to get formally looked at and diagnosed with this so you can get some help, because PAD is a very serious disease. It needs to be handled by the physician. If they elevate the legs 45 degrees, so sometimes I'll have I'll put them on and I'll elevate their legs because it's very comfortable and also to get the blood flow back. And to help drain the legs. If they're elevating their legs 45 degrees and you see that foot has become pale after 60 seconds, that foot is really pale. And then they put their leg down, so they're sitting, coming from that elevated state, and then they sit on the side and their legs are then dangling. How long does it take for the foot to change color, to like reperfuse the blood? How long does it take to revascularize? And if it's now revascularized, when the blood comes back, is their foot then lobster red? So if they elevate their feet, they're getting pale really quick. And if they stop that because they're like, oh my gosh, my feet are so pale, and they put their dependent feet down after having elevated them, and the feet are now lobster red, and it takes a while for that blood to come back, that is, if I heard that story, I would tell them they needed to tell their doctor that story, because I'm thinking peripheral arterial disease. All right. I love this little note that I wrote to myself. The best clients want to be in control of their problems. And I love that. It's particularly important for people with lymphedema diagnosis, because everything is pointing towards self-management. Even if they can come to me for regular MLD, but that's 1 hour, once a week, once every 2 weeks, once a month. The rest of those hours are their self-management. So the best client wants to be in control of their problem. And we need to understand if something is really a swelling issue or if it's just a compliance issue. And we need to understand that we can talk to them all day long about what's best for their swelling, but then also understand what are they actually going to do. So, I mean, the ideal thing is everyone's like, oh, Kathleen, I wish I could, put money in your pocket. I wish I could take you home. And so my husband, if my husband ever had a problem, he has a lymphedema therapist. His lymphedema therapist, which he married and he lives with, is going to give him care. But they're not going to be able to actually come to us every day. They have to, unless, they have the lymphedema therapist in the family that loves him, is going to give them the free treatment. They have to understand how to accomplish their self-management by themselves. And then it's important for people with lymphedema, people with edema, to focus on their quality of life. With the talking to someone about how they should be in a flat knit garment, it could be because we want their quality of life to improve because they were able to maintain their swelling and contain their swelling effectively. And then the flat knit can help them feel more normal. So it's a big discussion for them to get out of, like the circular knit stockings that they can act like it's a sock and pretend like they're everyone else. But the flat knit is a more serious garment. People don't like the feel versus a nice silky, more comfortable feeling circular knit. But we have to focus on their quality of life. And if their quality of life is going to improve because of the flat knit garment's ability to maintain and contain them, that is the best decision for them in the long run. If their lymphatic, if their limb is fluctuating, they have smaller days, they have bigger days, they have swelling days, they have less swelling days, the Velcro garments can help them because the Velcro garment is more adjustable than them having the garment in the bigger size for the big days and the smaller size, and which size are they going to be today. The Velcro garment can be a garment that they can wear every day. But if we're going to put someone in a garment that has stage 0 lymphedema right after their diagnosis, or they have not had any lymphedema, but they want that garment to wear occasionally or a garment to wear preventatively, do not have them buy that garment without being fitted properly, because garments are potentially dangerous if they are the wrong size. The last thing we want to do is have someone wear a garment because they think it's reducing their risk, it's helping their lymphatic system, but they're buying the garment that's the wrong size for them, the wrong shape for them, and then we're actually going against the lymphatic system. The lymphatic system is now having to fight this garment. So get them measured, understand. Our clients need to understand that they need to get fitted properly for that initial garment. Even if they have stage 0 lymphedema, if they have no symptoms, if all they feel is heaviness and tingling, they still have to get measured for the garment. And when the garment prescription comes in, we're more increasingly needing to take the adiposity of that segment of the body into consideration, not just the lobules, not just the severity of the disease, but how much adipose tissue is there, and how the garment has to also compress, thinking not just of the lymphedema swelling, but also the adipose tissue that's present where the garment is trying to do its job. Fibrosis, if someone has fibrosis, add nighttime compression. And then this clinical pearl for pumps, because I think I've even been kind of excited about the ideas of the intermittent pneumatic compression. Maybe you don't need to use it at just a low millimeters of mercury. Maybe what happens when you increase the pressure in the pump, and this clinical pearl was a pump pressure cannot exceed the resting diastolic blood pressure. So if you're trying to edge up on those pump pressures, know that person's blood pressure and have them understand that that is the upper range of what they should put that pump to. They should not put it to higher than their resting diastolic pressure. They can't squeeze themselves that hard. If someone has CHF or a PAD, congestive heart failure, peripheral arterial disease, don't use the pump when you're in the garment. You cannot add on the compression of the garment with the compression of the pump if someone has congestive heart failure, peripheral arterial disease, at least. And then they've done the research on it, and they found that the peristaltic pressure is actually better than the sequential constant pressure. So if their pump has the option of which type of pressures they have, that's the system that gets the compression from the bottom to the top of the limb, peristaltic is better than the sequential constant pressure. Really interesting clinical pearl, gynecological cancers that have affected, they've taken out the inguinal nodes, create hard to control lymphedema. So if the inguinal nodes are removed, and if it's a gynecological cancer, understand that that may be a more hard to control lymphedema than maybe other types of lower limb lymphedema and upper limb lymphedema. And if someone wants to see if, and this will be my last one, if someone wants to see if the garment has kind of a wicking effect, if it's going to be maybe a little cooler, if you can put it on an area that's going to be a little sweaty, do a water test on the garment. So take that garment, take that stocking, and then put a drip of water on it from like a cup of water and see, does that water sink into the garment or does it leave it and bead on the top? And then understand that if a garment beads on the top, that think of that garment next to a skin that is trying to give it water. And if it's pushing back and just letting that water bead on it versus absorbing it and having it go through and wick out, it's going to be a worse option for someone who's in the heat, who's sweating, who's feeling that maybe the garments are too hot for them and they don't want to wear them. So definitely do that water test. If a garment can't breathe, if it's just beading, think of how that garment's going to feel for the client in the heat. Okay, so that was my clinical pearls, my long video of my clinical pearls for the Medi lymphedema class. Again, go to Medi University and understand that all those resources are yours if you are a lymphedema therapist. Thanks and have a great day.